May I invite the chairpersons for the next session, Dr. K.K. Rajan, Professor, Department of General Surgery, KMCT Medical College, Calicut; Dr. Raghu Shankar, Professor, Department of General Surgery, P.K. Das Institute of Medical Sciences, Palakkad; Dr. Preeta S., Associate Professor, Department of General Surgery, GMC, Alapura; Dr. Bharat Veerabhadran, Consultant Oncosurgeon, KIMS Hospital, Trivandrum; Dr. Rishikeshan Nair, Professor, Department General Surgery, GMC, Trivandrum. We request you to kindly take your seats, please. The first presenter, Dr. Sunil, Professor and HOD, Department of General Surgery, GMC, Kottayam. Insights into breast and endocrine surgery. This is this present session. Over to the chairpersons and over to Dr. Sunil.
Thank you, chairpersons. Welcome all delegates. At the outset, I would like to thank the organizers of CASICON 24. And my thanks actually to Dr. C.S. Madhu, the radiation oncology professor and head at Kottayam during 2006, who initiated my interest in breast conservation surgery. And I also have my apologies because I am doing this very same presentation for the third time. The first in Jubilee ML Death and Memorial lecture, second in the peripheral conference at Kolanjeri. And since Dibin asked me specifically that general surgeons, the postgraduates are very much interested in learning breast, getting inspired by general surgeon doing breast oncology. That's why I agreed to do this. Thank you. So breast oncoplasty is actually helping us do wider excision volumes and so less risk of positive margins while doing breast conservation, and at the same time maintaining the shape of the breast, which we do not achieve with level 2 oncoplasties, and all in one sitting. And if you classify OBS techniques, you have volume displacement techniques, which are level 1 and level 2. Level 1 is where less than 20% of breast volume is removed, and level 2 is when up to 50%, and volume replacement is where more than 50% is removed. But actually I would suggest that you must be using volume replacement even in place where you are using level 2 procedures. Now, level 1 is quite simple. You excise with a margin, wide local excision, and then make a plane superficial and deep to the breast parenchyma, and then approximate the breast together. So when the volume removed is less, it doesn't really make a real difference, and so they can conserve the breast with a reasonable cosmesis. Now, level 2 procedures are multiple procedures, various procedures for various quadrants, and their complex pedicled breast reshaping is required. And you need a contralateral breast procedure if you are to achieve symmetry, and then the nipple has often to be repositioned. And this is how the lower picture shows how the breast looks like if you do not do a contralateral symmetrization. The breast appears quite small. Now comes volume replacement, where you mostly use local flaps based on the intercostal artery perforators. You have the lateral perforator, the anterior perforator, and the medial perforator. So the lateral is quite good because you have multiple arteries coming there and giving off perforators. You have the thoracodorsal, you have the lateral lower thoracic artery, and then the intercostal artery as well. So that pink area which I have shown, you get multiple arteries. They are very difficult to fail when you do it. And the lower picture shows how wide excisions can be done and replaced by tissues quite adjacent. And the picture on your right, lower picture on your right shows that this area beneath the skin, beneath the breast, the skin and subcutaneous tissue can be pedicled on the medial perforator, can be pedicled on the anterior or even the lateral. It's a very versatile thing. So complications are there, but quite uncommon. And this is actually a sentinel lymph node biopsy with dual dye. The flare technique, which I learned from my original trainee, Dilip Damodaran, who is here, I think, working in MER Cancer Hospital, where I use both fluorescein and methylene blue. The advantage is you don't have waiting time. You can see under UV light. At the same time, you can see the blue color also. So it adds to the identification rate in sentinel lymph node biopsy. So whenever you find node negative patients, you must be doing. So the same patient underwent excision with a level 1 oncoplasty, it's a small tumor. So the basic things I'm not going into, but then just watch the video. This I did under local anesthesia, which is quite small. So that's why I don't require to use cautery, because the tumescent goes and stops bleeding. So there is no much bleeding, but at the same time I don't compromise on the margins. And then when I finish, I do two things. One, I take cavity shave specimens from anterior, lateral, medial, superior and posterior, and then place clips, the simple vascular clips there, so that the radiation oncologist will be able to identify exactly where the tumor was located, in case you need to give a boost radiation, especially for a single microscopic margin. That would be quite useful. So that's I'm showing the clip application there. This is a LICAP based, but at a rotation flap. It's not an island or free kind of tissue. You can see it's a very simple thing that anybody can do. This actually the area beneath the axilla. The tumor was removed from the upper outer quadrant. So you can see that you just raise the flap to the area where the lateral intercostal artery, the thoracodorsal and the lateral thoracic artery would be giving off the perforators, and it can simply be rotated and placed. The fat beneath gives up the volume, and you can just undermine the tissue and close the defect. And this is how it appears. And then this is a thoracoepigastric flap for lower tumors, and you can see that the tumor is just beneath the nipple-areolar complex. So again, this I think I did under local anesthesia. So I'm marking lateral, long lateral and short superior, and then I'm excising the cavity shaped specimen from all around. And this is the flap being done. Again, it is not a free flap, but it is actually rotation, transposition flap, which is quite simple. There is no risk of flap failure at all. I just used a little bit of the skin also, because the tumor was close to skin. It was not a T4B disease, but tumor was close to skin. I had to sacrifice the skin also. So small area, I just use the skin. The remaining, I doubled up the flap so that it gives more volume. The tip was kept beneath. And so closure, so I had to actually remove a little more of skin from below because that was excess. And then finally, it's just a simple closure. Sometimes you need a little mobilization of the lower flap to close. Sometimes it is not required. And this is how it looks immediately. And then this is an anterior intercostal artery based flap, which I used. So this is the excision of an upper medial quadrant tumor. Use of this skin hooks are quite easy, quite useful because it doesn't damage tissues like you do with a Alice forceps. So again, I'm marking the margins, and I'm taking a deep margin, the shave margin. I'm not showing all the margins here. So you make it a routine that you take mark, shave, as well as you paint. I'm showing a picture of how I have painted later on. And you see that there is always a fat pad all around the tumor. So this is a large flap, so anterior intercostal artery beneath the breast. Actually, this for demonstration purpose, I took a very large flap just to show that it is going to survive. And so very large volumes can be replaced with this kind of flap, local flap, almost no risk of failure. There is no need for latissimus dorsi, DRAM for breast conservation, which I used to originally do from 2006 onwards. Now with so much of bulk, I can just either use a little bit of skin if I require, otherwise sacrifice the skin, and then you can, as I said, fold the flap upon itself, and then the, sorry, can someone help me with, I just, yeah, see it. This is the other last one. So I did local wide excision of another tumor in the upper outer quadrant and did a sentinel lymph node biopsy already. So this is a pinch test. I'm taking a tissue from the lateral aspect. So I pinch the tissue, and so that I know so much of bulk is available, and I make incisions on either side of the pinch, and then again check whether my incision is right, and then deepen the incision, and then up to the muscle layer in the lateral thoracic wall, and then this is the flap which is completely deepened, and then rotate it towards this area, and I excise the entire skin, and in this case, to avoid rotation, I just place it upside down, because if I had to use the skin, I could not have done it. So this is how it looks. This I just did 2 days back. Thank you very much. And this is a slide, thank you very much, but then this is how I paint this specimen. So I just paint it all around with acrylic colors. Obviously you have to dry the specimen, apply it, and keep it for about 15 minutes, and then put it into the formalin. So this long suture, I just placed a yellow mark there to know it is lateral, and then the red is for superior. And I usually remove a small strip of skin so that the superficial and deep margins you don't have to mark. Thank you.
Excellent presentation, Dr. Sunil. I have a query. You told there will be fat necrosis. How often you get fat necrosis, and will it confuse with recurrence? And how do you differentiate that if there is fat necrosis? One theoretical problem is fat necrosis.
I started doing this oncoplastic, this kind of perforator based only in less than a year back, and I would have done around maybe 12 to 13 cases. I've never had a case of flat necrosis.
Okay, so and symmetrization in the other breast, that will be a problem, isn't it?
That is the problem with level 2 oncoplasties, which is not required here, because ultimately the breast looks same size and there is no movement of breast from one quadrant to the other. Reshaping is not required. So there is no requirement of symmetry. It looks quite symmetrical.
Any queries from the?
Sir, if patient insists on symmetry with level 2 oncoplasty, and if there is the symmetry is not achieved, whether due to the preoperative or the postoperative factors, and what do you suggest?
Madam, are you asking me somebody who has already had a level 2 oncoplasty? Or primarily they are asking for breast conservation? I am not sure what you asked me. Is it that you have not done breast conservation at all and they are asking for whether symmetrization should be done or all that?
If
So
patient,
my point is there is no scope for level 2 oncoplasties any longer, although that is not the recommendations. My experience, obviously somebody was saying experience should not take upper hand over your recommendations, but I'm saying level 2 oncoplasty is quite difficult to do. You often require specialist training, you often may require an onco surgeon or a plastic surgeon to come in, and ultimately you have to do symmetrization, nipple repositioning, everything. Here a general surgeon can do, everybody has seen this, so simple a procedure. You don't even require a Doppler to identify the vessels. It's so constant position. So no repositioning, no contralateral procedure required.
Running short of time.
Yeah,
Dr.
it's expecting
Sunil,
a
one
question from a
question.
surgical oncologist.
Yes, sir. Just a quick comment, sir. Can I?
Yeah.
The thing is, like, the onus is on, as you rightly said, sir, the preparation and pre-op planning. So if that is done properly, because many times we fail to do that. Even myself, my personal experience, as I feel on the table we can decide and then do things. But
In the outpatient
I've
itself, I do this pinch test. So whether
Exactly,
I can get it from beneath the skin or from the sides, I make a decision in the outpatient department.
Excellent, sir. The thing is, the topic was on how do you instill confidence. So the learning
So
curve.
instilling confidence is just make an elliptical incision, elevate the tissue, rotate it to where you want, and close the incision. There is nothing new,
No, sir.
nothing robust, nothing complicated about this procedure. That's how confidence is instilled.
I think Dr. Binny is waiting.
Yeah,
Yes, sir, yes, sir.
my
Thank you,
question is, when you remove the skin, is it necessary to remove the entire skin or only epidermis and maybe the superficial dermis?
Yeah,
That is
the
the usual
typical,
thing we see.
If you look at all YouTube videos, you
Yeah.
find, or you ask any plastic surgeon, or I don't know about onco surgeons, they do de-epithelialization. It takes much more time. Excising the skin, it gets over in a minute. Whereas de-epithelialization is a very time-consuming. You have to draw 2-3 lines across, and then each bit
Slowly you have to cut it off.
What is
I'm
the
just asking, little more bulk will be there and probably.
bulk you can take from available tissues.
Okay.
You take how much bulk you want. So
Actually, whether it will rotate or not, you can plan with a cloth. You can cut a cloth in
Thank
that
you, sir.
position and rotate and see.
Sorry to
That is a
interrupt, sir.
good
We'll have to
planning.
move forward.
Thank you.
Thank you,
Thank
sir.
Running short of time.
I think
Thank you,
we can wind up the session.
thank you.
Thank you, sir.